On the 29th of November, MPs will have a free vote on assisted dying. The proposed bill to legalise assisted dying has just been published, giving MPs just 2.5 weeks of time to debate what is arguably one of the most important decisions they may face in their careers. This short video is to thank everybody involved for taking the time to debate such important decisions and to acknowledge the powerful emotive reasons on both sides of the argument. This video is also about raising awareness of the choice we have now but don't use, and some key issues which need to be addressed, and this is a great opportunity to do so. I hope it will inform and generate discussion based on fact and not fear. So, why am I doing this and what lens am I talking through? So my name is Claire and I've worked in palliative and end-of-life care for around about 30 years. I've worked in hospices, the community and in hospitals as a clinical nurse specialist. I've had the privilege of being with many hundreds of people and those closest to them as they approach the end of their life and when they die. I've led community hospitals in end-of-life care. I've delivered the Gold Standards Framework in acute hospitals, and I've worked as a specialist advisor in end-of-life care for the Care Quality Commission. I've also been a carer for a close family member who died at home. So a really diverse career. And throughout my career and in all of those different settings, I've seen the same things time after time. I've seen a lack of recognition of dying. I've seen a lack of recognition of advanced care planning. And these are some of the things that I'd like to talk about over the course of this short video. So I'm bringing all of those different experiences, all of those different roles, and they are the lenses through which I'm talking to you now. To expand on some of those points which I've briefly touched upon, my first point is just to start talking about palliative care and what really is a societal and professional lack of understanding about the role of palliative care. We tend to think of palliative care as an either-or approach, when in reality it's far more of a parallel planning, a side-by-side approach that we take with care. Palliative care is about supporting somebody throughout their illness journey by addressing the symptoms that illness may cause. It's not about curing an illness, it's about addressing the symptoms that illness causes. And you can dip in and out of it throughout the course of an illness. You can receive chemotherapy and palliative care at the same time, and indeed chemotherapy or radiotherapy can be aimed at palliation rather than cure. We don't always talk about that. We talk about and have an assumption that palliative care doesn't involve those things, and it does. Now, I've met people time after time that have been at the very end stages of their illness and receiving, for example, palliative chemotherapy, and they've been shocked to discover that it is indeed palliative chemotherapy. That open and honest conversation hasn't happened, and I can give a very recent example of a treating team being too anxious to use the word palliative with somebody that I know very well actually, and they know their illness is life-limiting. They are medically qualified, they understand the nature of their illness and the nature of the treatment, but prior to their palliative chemo, the doctor actually chose to cross out the word palliative because it was too scary to talk about. We need to get better at understanding palliative care. It might be interesting to hear that people receiving palliative care, there have been studies, and people receiving palliative care have been shown to actually live longer. So there was a study in Canada, I believe, of people receiving palliative care from the outset of their illness journey, and controlling their symptoms led to people actually living longer. So I think there is a misconception about what palliative care is. Throughout my career, there has certainly been a professional hesitance or reticence in referring people to palliative care, quite often until it is too late. That is just not good enough. So let's understand what palliative care is, how it can support somebody in and out throughout their illness journey, and let's introduce palliative care a lot earlier in those illness journeys or trajectories. My second point is a bit cheeky really. I'm going to have lots of sub-points in here, but I'm going to start by saying that most deaths occur in what I call a generalist environment. So I mentioned that I started off working as a really proud hospice nurse, and I was asked to go to the acute hospital. I remember thinking, I'm a hospice nurse, I'm special, I'm a specialist nurse. That's what I want to do. But it's when I went to the acute environment, I suppose I had my epiphany and realised that the vast majority of deaths will occur in a generalist environment, not under the care of a specialist palliative care team, and certainly not under the care of a hospice. So most people will die either in their own home or in a hospital environment, and cheeky fact, around about 30% of people in an acute hospital will be in the last year of life at any one time, something so many people don't realise, because we think of hospitals, don't we, as a cure-all place, but they're certainly not. So my sub-point in this is that death and dying and palliative care will, for the vast majority of time, fall under the care of generalist clinicians, generalist doctors, generalist nurses, and, may I say, families. Vast majority of care when somebody's dying at home will be provided by family members. So that's my sub-point. Another thing under this broad category, this broad point, is that we know terminal illness, having a terminal illness, will drive people to poverty. Leading on from that is that people who are in poverty, or people who are less comfortably off, will experience a higher symptom burden. So what I mean by that is the key symptoms, end of life, like pain, for example, or nausea, feeling sick and vomiting, will be experienced. Those symptoms will be worse in somebody who is less comfortably off. Leading on, expanding this argument, one of the arguments for assisted dying is that it will give a better death. I'll talk about that a bit later, but just to stay with the point of poverty, it fills me with huge unease that the way we are dying now is unequal. So some people, arguably the most vulnerable in our society, will be experiencing a worse death now, and we know that for a fact. I'm going to say something now which feels uncomfortable to say, but I think is worth acknowledging, and it expands and acknowledges what the Health Secretary, Wes Streeting, has said. He said in a statement recently that he felt palliative end-of-life care in the UK, whilst it was good, it was not good enough to consider assisted dying. So it's quite a bold statement, and you can hear my passion, you can hear my love for palliative and end-of-life care, but I hope I don't see it through rose-tinted glasses. And through all of those lenses that I've spoken about when I introduced who I am and what I do and where I've worked, I can honestly say that palliative and end-of-life care, is it good all the time? No. It's not as it should be all the time. If I can explain what I mean a little bit more, it brings into the discussion the generalist argument really as well. So things like, let me give you an example. Somebody may well be very well controlled on an oral painkiller, something like morphine or a medication to control nerve pain. They may have been on that medication for many months, many weeks or many months at a nice steady dose, and that's beautifully controlling people's pain. And what happens, what I've seen happen again and again and again, is that as somebody becomes more poorly, we don't plan ahead well enough, and we don't do a conversion to what's called a syringe pump. So we don't anticipate that somebody, through the natural process of dying, would become unable to swallow. If they become unable to swallow, you become unable to take the medications that you've been used to taking. So a person may well have been beautifully controlled on something like a morphine tablet. While they've been able to swallow, they become weaker, they lose the ability to swallow, they lose the ability to swallow their regular painkiller, and we forget to convert them to a syringe pump. Now that happens, it shouldn't happen. It absolutely shouldn't happen. That is not good enough. Have I seen it happen? Yes. Have I seen people come through A&E because that's been forgotten? Yes. Now this isn't complex, this isn't specialist, this isn't complex symptom management. These are basic skills which we are just not always getting right. And for goodness sake, when we talk about having a bad death, you are going to have a bad death if we've forgotten along the course of planning ahead to convert medications. So quite often we can do better with symptom control. And I'm not just talking about investing more in specialist palliative care. I'm talking about investing in our generalist workforce and ensuring that end-of-life care is part of everybody's skill set. We don't need to hand over to the specialist as somebody dies. So lots of points I appreciate under my key point 2, but I think they all sort of link together, and I suppose they come under the umbrella of my general unease. These points lead me to key point 3, I guess, and I'd like to talk a little bit about parallel planning. And again, we're not great at parallel planning. So I work now independently. I have my own company, Speak For Me, and I set that up because I've seen that parallel planning, advanced care planning, isn't introduced early enough throughout a patient's illness journey. There's not enough understanding about advanced care planning, and yet again it's something that we think specialist teams do, that it's not our job. We need to give it over to somebody else to do. We start it too late. And we can identify that through the mortality reviews that we do and the evidence that we have. So around about 5% of us have a document called an Advanced Decision to Refuse Treatment, ADRT, and around about 9% of us have a lasting power of attorney, and I'll talk about those in a bit more detail in my next point. So coming back to parallel planning, what would it look like in the ideal world? We know the story of every illness, so whilst every illness is unique to the person experiencing the illness, the trajectory or story of an illness is the same. So as healthcare professionals, we recognise that an illness has a beginning stage, a middle stage, and an end stage, like birth, beginning, middle and end stage. Birth is unique to each woman experiencing it. It's a unique and highly personal event, but the processes the healthcare professionals will recognise are the same. Those beginning, first stage, second stage and third stages of giving birth to a baby. We don't parallel plan, we don't introduce advanced care planning, we don't talk about what matters most to a person at the beginning of their illness journey. We don't take our heads above the parapet to yes, focus on the test results for today, but what does that look like in the overall picture of a person's illness journey, their illness story? Now, if we started parallel planning ahead, the great people that I can quote are the doctors Sami Winemaker and Xian Sao, and their work with the waiting room revolution. So we talk about unlocking the 7 steps to a better illness experience and introducing that parallel planning right from the very beginning of an illness experience. Taking time to look at the overall picture of an illness experience as well. So these are such important steps. Do we do them well now? No, we don't. We're not great at that parallel planning. We tend to leave things too late. We don't recognise that or talk about that an illness is life limiting, and we don't introduce options at the beginning. And so many of my guests on my podcast, we've highlighted these things. You can listen to some of the podcasts to really get a better understanding of those, and I'd recommend listening to Louisa Nicole when she talks about her husband's experience with myeloma. We're scared to introduce the possibility that treatment may, I'm going to deliberately say the word not stop, but when treatment may focus on palliation, not cure. We need to be talking about that early. We need to, for example, at the beginning of somebody with kidney disease, we need to be talking about what may happen at the beginning, middle and end stage of that, and that potential dialysis isn't something that somebody has to go through. We talk about those options early. When somebody has a device inserted to help a heart keep rhythm, we need to be talking right at the beginning at some point that device will have to be deactivated. What do? We leave it to the end, we pass the buck, and we don't have those discussions. So that's really why I've set up and do what I do, because we don't talk about advanced care planning early enough in a patient's journey. We don't parallel plan. So leading me on, and to really dive into what parallel planning and advanced care planning may look like, people that follow my work know that I talk about advanced care planning being a professional right. Sorry, I've got that round the wrong way. I talk about advanced care planning being a public right and a professional responsibility, and I feel incredibly strongly about that. So lots of my work is around education, advocacy and awareness about things like the legal steps that we can take now, the legal choices that we have now to protect ourselves, but we are just not using. So let me expand. Some of the things that we can do are creating a lasting power of attorney, or an LPA. So an LPA enables us to nominate a person or people to support us to make decisions, or make decisions on our behalf if we become unable to make those decisions ourselves. So people tend to think, well, I don't need that, I've got a next of kin. Around about 72% of people think that a next of kin can legally make decisions for you, but you can't do that. You need to give consent for somebody to make decisions for you or on your behalf, and you can only give consent when you've got capacity. By the time you've lost capacity, you can't give that consent unless you've thought ahead and created a lasting power of attorney. So a really powerful document. I work as an LPA consultant, supporting people to do that. When I was in clinical practice, again coming back to one of the reasons that I do what I do, despite being pretty senior in all the roles that I've done and pretty specialist, I was never really taught about lasting power of attorney. I certainly wasn't taught about the complexities of it. How to thoroughly check it, whether people have option A for life-sustaining treatment decision making, whether attorneys are primary attorneys, replacement attorneys, whether they can act jointly and severally, or jointly only, for example. So I acknowledge my understanding of LPAs was poor. I'd like to think it isn't now. But my point is that lasting powers of attorney is critically important. The voice of the person is so important, yet under-recognised by us as a society. Only around about 9% of us have got an LPA, and it's not well recognised enough by healthcare professionals. And things like a digital access of lasting power of attorney. A recent Which survey showed that whilst the digital access to view a lasting power of attorney has been in place for some years now, so many organisations don't even recognise that digital access route. So my gosh, we've got a hell of a lot of work to do in that front. Another legal element that I would like to raise awareness of is ADRTs, or Advanced Decision to Refuse Treatment. So that is a cracking document which enables you to refuse a specific treatment in a specific circumstance for a point in the future. So whereas an LPA, lasting power of attorney, is a really broad funnel, just nominating somebody to support you to make decisions, or indeed make decisions on your behalf, so to consent to or to refuse treatment, it doesn't give the nuts and bolts of what to say. It's based on the fact that the person making that decision knows you well. However, an ADRT, an advanced decision to refuse treatment, is really narrow. I can't remember if I said this already, but it enables you to refuse a specific treatment in a specific circumstance in the future. You have to be over the age of 18 to create an ADRT. You have to have the appropriate capacity to do so. The document has to include the statement of what you're refusing, under what circumstance, and you're refusing that even if your life may be at risk because of you refusing it. You have to sign it, and it has to be witnessed, but it doesn't have to be registered with a public body like a lasting power of attorney does. So how many of us have got an ADRT? How many of us have put that protection in place for ourselves? Because our choice matters, our choice is important, our voice is important. So why aren't we doing it? Only around about 5% of us have got an advanced decision to refuse treatment. So great opportunity to raise awareness about that important document now. So that's covered the sort of legal element. A sort of sub-point to that is what is called an advanced statement of wishes and preferences. So it's not a legal document, but my goodness, it really is a powerful document. Is too fancy a word for it. It could be, you could put down your wishes and preferences in just a piece of paper. Grab a pen and paper now after listening to this or watching this and write down what matters most to you. Write down what quality of life means to you. Write down who is important to you, why those things are important to you, what gives you purpose and meaning, what gets you up at the day in the morning. Because all these things, what make you the unique, fabulous and beautiful you that you are things that people need to know about if they need to make decisions in your best interests. And I always recommend my clients to think about doing an advanced statement of wishes and preferences, or at least talking about what matters most to them as part of creating lasting power of attorney or an ADRT, an advanced decision to refuse treatment. So that's the sort of choice we do have now that we are not using. So moving on to point 5, and I'd just like to briefly mention ordinary dying. So I'm not going to attempt to stand on the footsteps of the incredible Dr. Catherine Mannix. If you haven't watched her video, very short 4-minute video which explains ordinary dying, it's called In My Humble Opinion, Dying is Not As Bad As We Think, by BBC Videos. Do watch that. She's fantastic at explaining ordinary dying. But what I want to talk about is the fact that we see dying. Most of us don't see dying, do we? We see it through the lens of media, through films, through the media, through films, through soap operas, and that's not the reality of dying. It doesn't happen like that. So we see people as talking, saying their final special words and then boom, dying. That's not what happens. Dying is a process. A predictable process. We recognise that process of ordinary dying, but we don't talk about it. And again, there's a lot of research that we can refer to that says we don't talk about ordinary dying. We don't recognise ordinary dying. We don't use words like your loved one is sick enough to die. So we're not good at recognising dying until it is far, far too late. And that means we're not good enough when we're not recognising early enough, preparing for dying. And I could give you example after example after example of people being very, very close to dying, and this hasn't been acknowledged in the settings that we've been working in, and we just need to get better and be more honest about what ordinary dying is. I would love it if that 4-minute, In My Humble Opinion video was played as part of every healthcare professional's medical, nursing, whatever, healthcare professional training. It would be a game changer. So I'm going to try and draw all of this to some sort of conclusion and summarise my key points and why I've made this video. So in response to the proposed bill for assisted dying, there are a number of things that I think we need to get straight first. And that's to be clear about what palliative care is, and to be more open and honest about introducing palliative care throughout a patient's or a person's illness. We're all people, we're all mortals that are going to die one day. We need to appreciate that most deaths will happen under the care of generalist teams, either in hospitals or at people's homes, and be honest enough to say that the way people are dying now often is not good enough, and we can improve things. So people dying in pain the vast majority of times is avoidable. We need to be brave enough to introduce planning ahead from the very beginning of a long-term illness journey. We also need to raise awareness now of the legal steps that we can do now to take advantage, to take control and implement the control we could have over our lives, but so often we don't use. And we need to understand and talk about ordinary dying. So I've made this video because I feel really strongly, that introducing assisted dying is a little bit like putting a roof on a house before we've even built the foundations of a house. So I would urge everybody involved in this critical, literally life changing debate to find out about the choices that we've got now, to use the correct terminology, and to advocate for real choice, and to be using the choice that we have now before we consider voting on assisted dying. So thank you for listening, and take care everyone.